Generally, no. There is one uncommon kind of lung cancer called bronchoalveolar cell carcinoma, which tends to spread just within the lungs, and so that is the one exception. But in general, no. And people develop a cancer of any kind when their immune system is suppressed. It tends to behave more aggressively. So the reason for not transplanting people is concern that the cancer will come back in a short period of time.
The question, in case anyone didn't hear it, is if a child gets bad liver disease due to alpha-1 and needs a liver transplant, will that liver then produce alpha-1 antitrypsin normally and therefore cure the disease? Or will it become affected by the genetic condition? So the answer is that the new liver will continue to produce normal alpha-1 antitrypsin throughout its lifespan. So from that perspective, the issues related to alpha-1 antitrypsin deficiency should be avoided going on through life. The process of having a liver transplant comes with its own issues. So sometimes we talk to families who are facing that as the idea of replacing one condition with another condition. So you've got a whole new set of things to deal with, but we choose the timing of liver transplant to try to ensure that the issues you have to deal with after transplant are going to be much less troublesome than the ones you were dealing with before. So to start with the stem cell question, there are a number of labs in Canada working on stem cell research with a variety of different focuses, and whether any of those are thinking particularly about alpha-1 antitrypsin deficiency, I'm not sure, but I don't think so. But the processes to be overcome in trying to develop stem cell therapy for a number of different diseases are very similar. The hurdles that have to be overcome between where we are now and the day when it might be a clinically usable treatment, those hurdles are very similar regardless of the condition that you're targeting. So there is work in Canada and elsewhere. It's a very hot area for research at the moment, including at SickKids, which has a major focus on stem cell research. In terms of vitamin D, Beth Halliburton is going to talk after the break a lot more about the details of nutrition. I think she's probably going to say 1,000 units a day is a good dose for an adult to consider taking. For children of different ages, we generally check levels and adjust doses depending on that. Typically, we'll start at about 400 units. And the preparation, I don't think is too important.
I don't see an obvious reason on the face of it why one would affect the other. No. Yeah. We wouldn't. I think if it were shown that people with alpha-1 were more at risk of specific complications that the prolactin might prevent, then it would be logical. You could expect that if people after lung transplant live for many decades, that there might be a rationale for it. I think in current practice, we don't think that there's a reason to continue it after lung transplant. So the cost in lung transplant is high in the first year, and then decreases as because a lot of the costs are associated with the surgery and the hospitalization and the ICU stay, whereas in the long term it's more medication costs and follow-up visits. The cost would be less expensive than would be similar probably in the first year to augmentation therapy, and would be significantly less from then on.
Of course, then there's all those other hospitalization prior to when our alpha lungs are being destroyed along the course of the pathway, huh?
So if the lung function deteriorates after transplant, usually it would be for different reasons, not because of recurrence of emphysema. And those reasons, which would include things like chronic rejection, we wouldn't expect the augmentation therapy to help with. So so we wouldn't, although people can and do lose lung function after transplant, I don't think that augmentation therapy would be the solution. So there are criteria and there are provincial rules about it, and the rules are based on studies that showed increased survival in patients who were given oxygen, randomly assigned to get oxygen or not. And so in Ontario, people have to have a PO2, which is a partial pressure of oxygen in the blood, of less than 55 or less than 60 with certain complications. People can also qualify on the basis of showing an increased walk distance or decreased symptoms with walking while they're using oxygen versus while they're breathing room air. So there are rules about who qualifies. We run into this a lot with people who are very sick pre-transplant, and they're coming to the exercise with a physiotherapist, and we want them keeping their muscles strong and their heart strong. And some people need to be on 100% oxygen via face mask in order to do that, and some people are still very limited in spite of that. We would generally like to see people's oxygen saturations at or above 88% during exercise, but in some people we have to tolerate lower oxygen levels. I think if people's oxygen levels are dropping lower than that in a sustained way, I think they should be exercising in a monitored setting. I don't think pushing yourself at home with a saturation of 80% is a good idea.
So I think if you look at a large group of young children with alpha-1 antitrypsin deficiency, we know that from the data that we have, which isn't perfect, that around about 10% will end up needing a liver transplant. Now, whether that's rare or not is an interpretation. It's also data that comes from places like SickKids, another bigger study in kids from Pittsburgh, which has a similar, what we call referral bias. We tend to collect the kids that are having some problems. So arguably, you could say that 10% is a little high if you look at all young children with alpha-1 antitrypsin deficiency. Now, in that big group that we're imagining, the ability for us to predict which ones of those kids may go on to need transplant is far from perfect, especially at a very young age. So when you're starting out at 6 weeks, we really usually have no idea at all whether you've got a transplant in the future or not. As the next year or two goes by, some of those kids will start to declare themselves as having worse liver disease, and those are the ones we know we need to look at more closely as the further time goes on. Even once the children get cirrhosis, so bad scarred liver with other complications starting to appear on ultrasound, for example, we know that of those children, lots of them will keep going strong for 10, even 20 years before eventually getting to the need for a transplant. So the prediction over that sort of length of time becomes very challenging, and we're just not good enough at getting it right at the moment. Does that help?
Semi. Dr. Ling, I think on a positive note, can we say to these families here today, though, that the number that don't require transplant is high in that group? That is a real positive thought. I know that doesn't give you, it gives you some hope, I guess is what I'm saying, that the chances are, and I know as our research is so.
I think it's a good way of looking at it to flip it and say 90% of children with alpha-1 antitrypsin deficiency will not need a transplant. The other way I look at it and describe it to families is as a positive thing to know that there's an option. Often this idea that bad liver disease is untreatable is the thing that sticks in people's minds, and knowing that there is an option, even though it's a big step to take, I think can be helpful. And then the other thing that can be helpful is to look at the long-term survival after liver transplantation. In children, for example, at SickKids, 90% of those kids are still going strong at 5 years, which is the standard sort of time at which outcomes are evaluated after a liver transplant. So even if the worst happens and you end up needing a liver transplant as a child, the outcomes after that are still very positive.
Certainly, I think, too, we don't want to diminish your fears and anxieties for yourself and your child. I think the other thing, too, on a positive note to our esteemed researchers and scientists and doctors and everything, the amount of research and technology is improving daily. And so, hopefully in that period of time, there will be improvements again to really help your child. I know that doesn't do anything for someone that is immediately sick today, but again, I think that they're doing leaps and bounds compared to what we were 20 years ago when the disease itself was, it's totally unknown. They've come a long way, and with hopes.
It's probably not a very good place to store them. The concern is just that if there is an open flame and the oxygen is somehow leaks out of a cylinder, then the combustion gets accelerated a lot, and is, if anybody lights a cigarette when they're on oxygen, they get a nasty surprise. So in principle, the oxygen is contained in the cylinder and it shouldn't be diffusing out, but probably it would be prudent to put them somewhere else. It varies, but there would be somewhere around 60 at any one time. Well, the first lung transplant was done in 1983. So we are, 29 years out from that. There are people who are in the 22 or 23 years out who are still alive. Most people, the majority of people, do develop chronic rejection and bronchiolitis obliterans syndrome. So many of the long-term survivors would have reduced lung function. And the median survival in our program after lung transplant is between 6 and 7 years, meaning half of people would live longer and half of people would not live that long. About 3% of the transplants we do are retransplants, meaning people who've had a previous one. Many people, because of other health problems that develop, including things like kidney function, problems with the kidneys, may not be considered suitable candidates for a second transplant. Generally, people over the age of about 55 would not be considered suitable candidates for a second transplant. So there's a fairly small group of patients who we think are good candidates for a retransplant. Outcomes after a second transplant are not as good as with a first transplant, relating to people's overall health, I think, at the time of the second transplant.
Yeah, I'm not a gene therapy expert, but there are different ways of delivering the corrected DNA to the cells where they're needed, and various methods of doing that, and what actually goes into the injection to enable the DNA, once it gets into your bloodstream, to then get into the cells and then into the nucleus of the cells where it needs to work. So there have been various techniques tried and continue to be researched to get that right. That's one of the big hurdles, and the idea of the stem cells is one technique to try and get around some of the problems that have happened using other approaches. So this technique that I was alluding to, based on that study out of Cambridge, would involve creating liver cells from stem cells from the same individual, and then re-infusing them back into the liver in the hope that they would then repopulate the liver and grow and multiply in the affected liver with normally functioning cells. That's the hope of that technique. But you're right, there are other ways of going about it. And one of the nice things, if this induced pluripotent stem cell approach that I mentioned should prove to continue to look promising, one of the nice things about it is that it avoids the need for viruses where the safety issue, there's always at least a small question mark over that. It also avoids the need to use other kinds of liver cells which are produced in labs from various techniques, but often they start out with a cell that has a cancer potential to it. So there's another question mark over those techniques, although the cells are rendered as safe as they can be. But with this technique, those hurdles are bypassed by using this kind of technology.
I actually get a lot of questions from parents about pain. One of the things is that, with the exception of a couple of very unusual complications of liver disease generally doesn't cause pain. Unless you have sort of a stricturing disease or something unusual. Sometimes when we see children who have advanced liver disease, they may have enlarged organs and basically a smaller space in their belly. So we do have kids who have abdominal pain more related to feeding, bowel movements, things like that. But it's typically not true liver pain. It has more to do with the space they have available within their tummy. I would say to a certain extent you can have, I mean, if you think about it, bowel problems in toddler ages are very common anyway. 30 to 40% of all kids complain of some abdominal pain and maybe some constipation. So it's common in the general population as well. I think anytime that you add a chronic medical condition, the things that are common in the general population also become more common.
Yeah, so it's a great question, and I don't think there is proof, you know, with sort of 40-year follow-up studies to follow the same individuals from childhood through to later in adulthood. So I'm not aware of any data on that. I'm not sure if Dr. Binney knows of anything, but I think your point that you make yourself is the key thing, that there's every reason to expect that because they are, the children with liver disease are usually PIZZ, there's every reason to expect that they are susceptible to lung disease as they get older, and therefore to take all the right precautions to do everything to try and prevent and delay that.
I can just interrupt. So we, as Dr. Ling says, we would have every reason to think that those people would have the susceptibility of other alpha-1 patients or people to emphysema. But a critical aspect of the young onset emphysema is generally smoking. And if people abstain from smoking throughout their lives, even people with severe alpha-1 antitrypsin deficiency, while they may have some lung involvement, they are thought to have a normal life expectancy, or described as having a normal life expectancy. So I think the key thing in somebody like that would be to avoid smoking in any form, and to take care of the lungs in other ways in terms of exposure to dust and vaccinations and that sort of thing.
Yeah. So there's some interest in trying to understand why certain individuals with alpha-1 antitrypsin deficiency get liver disease where others don't. And one of the potential reasons for that is that there's other little things that are aggravating the liver in certain people. We look at this in a variety of different liver diseases, and often you can find genetic conditions where instead of having the full-blown genetic condition, you have half a dose of it, which usually people would get away with no disease related to that. But if you add that on top of an otherwise also a liver that's otherwise affected by another condition, then things maybe go worse for that person. So if you add conditions together, then you maybe get more problems than you would with just the alpha-1 antitrypsin deficiency, for example. Now, for those two in particular, I don't know that there's any work particularly looking at the two together. The hemochromatosis is, of course, a treatable condition that can be managed with
by bleeding, or?
That's the mainstay of treatment. That's correct. So the impact of hemochromatosis on top of alpha-1 antitrypsin deficiency, I think, certainly can be minimized through that approach to treatment. Whether you get back to baseline or whether there's still a slight increase in potential harm to the liver, I think is difficult to say. Yeah. So after a liver transplant, there is the potential for rejection. In fact, a large proportion of children and adults, for that matter, will have episodes of acute rejection. So these are manageable with medications, usually picked up through screening of blood work. and we see that as eminently treatable. Somewhere between 30 and 50% of people that have liver transplants will have episodes of rejection during the first year. Longer term, there is the potential for chronic rejection or other conditions affecting the liver that can lead to accruing damage in that liver and eventually the need for repeat liver transplant. Now, the need for that is actually not common, typically, although the liver, we can sometimes show that it's not perfect, it's rare for it to become affected to the extent of needing a repeat liver transplant. We are now getting to the stage where we're starting to get a reasonable number of 15 to 20 year outcome patients. So we're starting to get a sense of where the numbers are at that sort of duration out from transplant. First liver transplants at sick kids were done in 1986, so the longer term outcomes are we're just starting to get a feel for that. And of course the other problem is that what we're learning now about the 20-year outcomes reflects what we were doing 20 years ago with transplant, and things have changed fairly significantly in the meantime. So we would be hopeful that what we do now has a much better longer-term outlook than what we were doing 20 years ago. So if you mean the concentration of alpha-1 antitrypsin in the blood test, for us it goes from about 1.2, I think, in our units is the lower end of the normal range. In people who are heterozygous, so they have one copy of the abnormal gene, we're seeing it around 0.6, for example, 0.7. And people who have the two abnormal copies of the gene, it's down at 0.1, maybe, that sort of range. The study of carbamazepine is the drug that's commonly known as a treatment for seizures, is just starting. The recruitment age goes from 14 through to adult years, so they're including an adolescent teenage component to it, which is actually great because commonly these studies take a long time, if ever they come to pediatrics. So it's nice that they're including at least part of the pediatric age range right from the outset with that work. I really have no idea whether it's got a future to it or not, and this initial study will give us a better sense of that. If this study shows a positive outcome, then I don't see any strong reasons why it couldn't be used in children. It's a drug that is already commonly used in a large number of children with seizure disorders. So I don't think there's a predictable reason why this approach wouldn't work in children if it turns out to be effective in adults. But that remains to be seen. The follow-up for this study in their protocol is 1 year on treatment, with some receiving the drug and some receiving placebo. And then I think a further year of follow-up after that. They need to recruit a certain number of patients. They're running it out of one center in the US. And the other determinant of the total duration of the study before we see results will be the rate at which they can recruit patients into their study. There are fairly tight eligibility criteria related to the liver, and the study requires some invasive testing where they want to measure blood pressures inside the liver. So it's quite a lot to ask of the potential participants. So we'll see how well they manage to recruit to the study. I think we're still a distance from that. We've actually invited the author of that paper to come to Sick Kids, hopefully over the next 12 to 18 months, to talk to us about where they're at with their program in Cambridge. That paper was just presented in the fall of last year, so it's really brand new. I think that when the press gets hold of these things, the problem is that recurrently you get the sense that it's, you know, about to hit the market and be available widely for everyone. I think the reality is that these things take a lot longer than we would all hope. And that's for good reasons, to make sure that these approaches are very safe. And when we're considering this sort of technology, it becomes even more important to make sure that, that there's a high level of safety when we're doing things that really haven't been done before.
Well, there's a lot of interest in trying to get lung tissue to regenerate. And there isn't any proven therapy that involves infusions of cells. There have been some very interesting experiments with taking lung tissue and dissolving away the cell component, and then in a special kind of incubator infusing other cells. And there have been some experiments, for example, in mice, showing that you can get some somewhat functional lung tissue that works at least briefly after taking a sort of a scaffold of all the protein that normally holds the lung together, and getting other cells to come in and stick to it. And if the cells come from the host into whom you want to put the lungs, say somebody who needs a transplant, if you're able to generate the right kind of cells from the adult, get them into the incubator so they repopulate the lung, and then put that lung into the host, then you could get around all these issues that we have with immune suppression and rejection and so forth. So there's some interesting experiments that are working along those lines, but there are all sorts of issues around them, and the demonstrations of that you're able to produce functional lung tissue from that are really very kind of crude and limited at the moment. So those things are still, I think, a long way off in terms of being used in people. There are various outfits that advertise that they will give stem cell infusions, and really I don't think there's much belief that that does anything useful in terms of sort of random infusions of stem cells. So I work with some hardworking surgical fellows who are constantly flying all over the map to retrieve lungs. In Canada, there are lung transplant programs in Toronto, in Montreal, in Edmonton, in Vancouver, and there have been some transplants in Winnipeg. So any organ donor in Ontario or the Maritimes would usually be the lungs would usually be offered to our program, or in Quebec, if they don't have a suitable recipient, then those lungs would be offered to us, and occasionally from the United States, although most often there would be programs in the United States that were able to use the lungs. So there is quite a wide area. We have had some lungs from BC as well.
And the other question was, how long from the exit of the donor can that lung stay alive to enter the recipient?
Well, historically, it's been the shorter the better. And so that's the time where the lungs are not receiving blood flow and are sitting on ice in a cooler. The thought is the lungs are degenerating, and that time should be kept as brief as possible. There has been a lot of work in our program in particular in trying to do a number of things with the lungs before they're transplanted into the recipient. And so there's a system that some of you might have heard of called an ex vivo circuit, in which the lungs are, rather than kept cold in a cooler, are placed on a circuit at body temperature. The arteries and veins are connected to a system that pushes fluid through the lungs, and the airways are connected to a ventilator. And so you have air going in and out, you have fluid flowing through them. And this has a number of purposes. One of them is to allow us to assess lungs where it's questionable whether they're going to be suitable to use. But if the lungs are just a little bit, say, swollen with fluid, and with removal of fluid they perform much better, then we'd be happy proceeding with a transplant. The long-term interest is in treating the lungs, say that there's a pneumonia, to treat it with antibiotics, or to give treatments that might allow the lungs to perform better and have less injury at the time they're put into the recipient. So there's a lot of interest in that system, and one of the troubles is that of all people who are potential organ donors, it turns out that in only about 20% of cases are the lungs usable for transplant for all sorts of reasons. And because the availability of organ donors is really the limiting thing in lung transplant, the thing that limits the numbers of transplants we do, there's a lot of interest in trying to increase the proportion of lungs that are usable.